So, I am going to tell you what I'm going to attempt to tell you first and then work backwards. So I got some fancy words. One is validity, one is epistemology, and then another concept is literally false, metaphorically true. So how many of you in here can tell without asking somebody how they're feeling inside? Okay, like accurately, can you tell for sure the exact intensity of pain that somebody else is feeling? No. In a very unfortunate way, the best we can get is proxy measurements. So we can get some kind of information from some request for that information from somebody else. They can tell it to you verbally. You can apply pressure to them. You can apply touch to them, and how they respond can give you a proxy for how they're feeling, but you don't know for sure. You can't hit a target you cannot observe. Right? So there are a lot of things in hands-on therapy that are literally false, but metaphorically true. There's a lot of mechanistic claims that don't hold up to rigor. They are not what they say they are. If something is what it says it is valid. So if I wanted to measure speed, could I measure speed with just a ruler? I can't measure speed with just a ruler. I also need time, because it's distance over time, and then I can figure out speed. So if I told you that I know how fast something is going and I only have a ruler, should you believe me? You shouldn't believe me. If I tell you that I know I have reduced your pain, should you believe me? I need to ask you, right? So I can't hit that target. So it is unfortunately not valid for a hands-on practitioner to tell you they know they've changed your internal state. You have to tell them. So much of what we do, because of the fact that we're outside of the person, we can't sense what's inside them other than them telling us, we can't make valid claims about that. What we can make valid claims, so who can tell which arm isn't moving as far? Right? So it's this one, correct? It's my left one. Anybody can tell that who is able to observe it. There's definitely people who won't necessarily be able to observe all signals, right? So there's definitely people who, when I do that, they won't necessarily be able to observe it. That is what it is. But if you can observe it, you can figure it out. Do you know, just from me doing this, why it's like that? You can't. You can investigate. Do you know, right off the top, if this is because of a nerve, a muscle, a ligament, right? Can you observe the nerve? Can you observe a nerve directly? Not as far as I know. You would need something to extend your perception. You would need some form of diagnostic tool that can take a signal and turn it into something you can observe. So unfortunately, you can't observe a nerve. Can you directly observe a muscle? Not really. It has to be open. So you'd have to break the skin to directly observe the muscle. You can observe it by proxy, right? So if you know what the muscle's supposed to do and it doesn't do that, you can assume that in all likelihood, the muscle is not functioning the way you would want it to. So again, can you differentiate this between nerve and muscle right now? You can't, right? You can't observe it. You can't tell if that's fascia. You just can't tell. You can have tests that you believe test fascia, apply those tests, and depending on the result, you can infer, you can guess that is fascia. Can you know? You cannot know. Is my fascia on my left arm the same as my fascia on my right arm? Is the tissue laid out the same way? No. So unfortunately, the moment you go beyond the movement characteristics of something, especially what you can observe from outside, either it squishes or it doesn't squish, or it moves or it doesn't move the way you've requested it to. Once you go beyond that, your ability to know for sure what it's doing is gone. So that's where epistemology comes in. So we already talked about validity. Is something what it says it is? Is this a test of nerves? Sort of. Right? But it's also a test of muscle. It's also a test of everything that would be involved in generating that movement. But I can't differentiate them. So it has no validity for me to break it apart into the small pieces. But if I say the left arm don't move good, is that a valid statement? It's a valid statement. It is what it says it is, right? If I squished here, and it didn't squish, and I said it didn't squish, is that a valid statement? That's a valid statement. If I squish here and it doesn't squish, and I tell you it's the lymphatic system, is that a valid statement? Unfortunately, no, it can't be. So epistemology is essentially a theory of knowledge or a theory of truth. The questions that have to be answered is what can be known, how can it be known, and who can it be known by? Can you know that that's the lymphatic system if you're outside the person? No, right? So we have an issue with validity as far as claiming mechanisms from tests. We have an issue with epistemology because if we say anything that's internal, we can't observe it appropriately unless we sometimes have other instruments to do that. So earlier today, there was a demonstration using ultrasound-guided treatment. So if I wanted to talk about specific tissues, if I've got an ultrasound, can I do a better job? Absolutely. Can I talk about a nerve accurately with ultrasound? No. I can talk about the return of differences in tissues. So I can assume something's a muscle, I can assume something's fat, I can assume something's a ligament or a tendon, depending on where that ultrasound is. But if I have the ultrasound, I can do it. I think most of us don't have in-office ultrasounds. Most of us. Some of you may, and that's fantastic. You can make more claims. So again, we've got validity, we've got epistemology. Again, what can be known, how can it be known, and who can it be known by? If I tell you a story, I'm an osteopathic manual practitioner. Has everybody, or have some of you heard of strain counter strain? Okay. Do you know possibly that the gentleman who started it, Larry Jones or Lawrence Jones, what he had was a case of somebody he was trying to treat for about 6 weeks. He said he had an acute psoriasis. Essentially what he was saying is that I know his psoas isn't doing right because when he stands up or when he lays down, he's got pain in this particular place. So there's an issue with the claim. Don't worry about that point. The person was telling him, I have pain here, it stays here, this is what happens. He was doing HVLA to this gentleman for about 6 weeks, didn't work, right? Guy said it hurts, it hurts, it hurts. So one day he comes into the office, he says, I'm gonna find a position that you're comfortable in. So he finds this position, he turns him into a pretzel, says do this, do that, and he's like, okay, I don't feel anything. Walked away, treated somebody else, 20 minutes, comes back, guy stands up, says, I feel better. So he laid still in a position where he had no sensation for about 20 minutes, right? He says, I feel better. He called it spontaneous release by positioning, okay? Does that sound like it's accurate to what he did? Now, I would say yes. He said, I put him in this position, the thing changed when I came back 20 minutes later. I didn't do anything other than put him in that position, so it was spontaneous release by positioning. Sounds accurate enough. What he did then is he did it for 19 minutes on the next person, 18 minutes on the next person. So when you look at strain counter strain or in osteopathic manual therapy, most of the indirect systems say hold for up to 90 seconds or until, hold until change is felt or up to 90 seconds. Because Lawrence Jones figured out that if I go longer than 90 seconds and it doesn't do it, it's not going to, okay? That sounds like an appropriate set of observations through the thing he was doing to then say, yeah, I buy everything you're saying. Because it's a behavior that's repeatable. He tried it on a bunch of people. After 90 seconds, if it didn't work, it's not going to. What he then did a few years later in the 70s, there was a physiologist who was working in osteopathic schools, Irvin M. Kaur. Irvin Kaur was a physiologist. He had done some stuff with the Air Force, so he was a physiologist. He came up with what in osteopathy was called the facilitated spinal segment. Right? So basically what he did is he measured galvanic skin response. So he just put this thing on the spine, he measured the response that he got through that device. He had DOs check the spine, and the DO would say, the problem's here. He would put the reader there, and it would look different than the other areas, right? So he said, well, DOs can figure out where the galvanic skin response is different, but the problem was he didn't properly check that all out. The facilitated cord segment concept doesn't hold up to scrutiny, unfortunately. But what happened in the 70s, Larry Jones said, you know what? The reason my thing works is that. So he never tested it. He took somebody else's word for what they found and said, the reason my stuff works is that. So he didn't test it. He didn't do any of that work. He just imported it because he thought it was sexy and cool, right? That is not valid. It doesn't line up with anything that Jones did, and everything Jones did was good. So now when you hear about strain counter strain, you're going to hear about things like facilitation, right? because it got imported as a concept that had nothing to do with how he figured it out. What Lawrence Jones did from start to before he claimed a mechanism was very good, because he was acknowledging that he was outside of the patient. He was acknowledging what he could get from the patient. The patient told them how they felt, right? So told Lawrence Jones how they felt. The change was consistent. At 90 seconds, you had a cutoff. Any longer than 90 seconds, if it wasn't going to change, it didn't change. That was all acknowledged from the environment of observation that he had. He didn't need to know anything about your nerves. He didn't need to know anything about your muscles. He didn't need to know anything about your fascia. He just knew that when he did this thing consistently, he positioned you, you told him you felt less. He, scale of 1 to 10, what's it right now? 5. He positions you, what's it right now? 1, and he held you there for up to 90 seconds. It changed or it didn't. He had no need to know anything about the inner workings of your body. He had a system that was developed from the external environment of observation that worked consistently. Then what he did is he screwed up. He added somebody else's idea in as the explanation. Most of what you're going to experience in hands-on therapy as far as the claims of mechanism is exactly that. The story, if you track it down through historical resources, is the same. Do you need to know, if you do a motion test, if it's a nerve? No, the only reason you need to know if it's a nerve is if no motion. So if I ask you to raise both of your arms and it looks like this, okay, well, you need a physician. They need to do further investigation. I need to figure out if something's torn or the motor nerve is gone, right? I'd have good reason to figure that out if I asked you questions. There was some kind of trauma. But what am I going to do about this? Right? Nothing. I need a doc. So you have no need to know what's internal. If you understand that you behave in a predictable way, you get predictable results. You don't need to know. Because when you go and tell somebody, if you are palpating, say, relatively close to the lumbar spine, they feel some tenderness, and you say, it's your QL. How do you know? You can't observe the QL. Is the QL very close to the lumbar column and in front of the entirety of the erector mass? So how accurately can you palpate it? You can put pressure and deform it, but can you know that what you're picking up is not another tissue? Not well. You have to make assumptions. The more you go beyond what you can observe directly in the form of motion, the more you have to make assumptions, and the more each one of those assumptions has to be correct. So you don't even need to know the mechanism, but you need to know and have a framework through which you can find something, do something about it, and get your consistent result, retest it. So literally false, metaphorically true. When Lawrence Jones brought the facilitated chord segment in, it became literally false, but it is still metaphorically true, because the behaviors he suggested work consistently. So you didn't need the mechanism to get the result. He brought the mechanism in after. Most hands-on therapy was generated in its roots prior to our current ability to assess these things. They didn't need to know. They got good results. They made up stories, but they didn't need them. However, because humans function on stories, they're useful. So if your story happens to be, that don't move good, I do this, it moves better, it works really good. Now the other deal is, do I need to pay attention to the idea that somebody told me about how it works, or do I need to pay attention to the person who's right here, right on the table? I need to pay attention to them. So if I have an idea that if it doesn't bend left and I bend it left, it should get better, well then if that's my only idea, I'm going to bend it left. And if the person says ow, 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 and it doesn't get better, did I do the right thing? No, I did the wrong thing. If I bend it to the left, short of where they say ow, and I wait, and it changes, well, it could be myofascial release because I waited. It could be neural inhibition because I waited. If there was some swelling and I waited long enough and it was neural inhibition or MFR, well then all of a sudden the pressure is off the vascular system. Well, now it's a lymphatic treatment. How do I tell the difference? Do I need to? Now, if you're aiming at something like swelling, it does make a difference because you need to help generate motion. But other than that, it doesn't necessarily matter. So you all probably get very good, consistent results. And the story doesn't matter because you all probably tell different stories. So the story matters less than one might hope. So if you talk about, this didn't move good, I did this, it moves better, you're on the right track. You're saying accurate things. You're making very few assumptions. Everybody can agree. But once you say, it's definitely a ligament, we run into problems. So that's where hopefully I've tied it all together, where we talked about validity. Is it what it says it is? We talked about epistemology, what can be known, how can it be known, and who can it be known by? And we've talked about literally false, metaphorically true. Hopefully that brings it together to allow you to empower yourself to say, I don't need the story. I need to pay attention to the person who's here. I need to work on them in a way that they respond positively to. And if it changed, we're in a great spot. So thank you for listening. We're all good.